therapy and follow-up. Stress test for further evaluation as this patient has no symptom at present, or urgent invasive management.
এটা কিছু বলবেন পরে ইয়ে ভাই একটু বললে ভালো হয়। এটা পরে দেখো।
আচ্ছা।
This is a real life scenario, and this is something that we find and people miss. As Hafiz Bhai was saying, this patient should not have any stress test, number one. Number two, medical treatment should be started aggressively immediately, but this patient should have urgent invasive management. Multiple risk factors, typical ischemic chest pain lasting for hours now may not be present, and there is typical biphasic changes without presence of LVH. There is no LVH. There should not be any T inversion, but it's there. And it's mid precordial leads. All this suggests this is a very likely Wieland's syndrome. Hafiz Bhai, your comment, please.
So, I tell this patient should not go to the stress lab. And it is very important to recognize, and as you know, that even unstable angina, the coronary anatomy and physiology matters. Because unstable angina, because of a diagonal problem or a OM problem or a PDA problem is one thing. But unstable angina due to ProxLAD, if you look at the whole cardiology database, it has mortality implications. So it is very, very important that we recognize this. Otherwise, the patient's life can be at risk.
Shahana, proceed.
We planned coronary angiogram for this patient. We planned coronary angiogram for this patient, and we found significant stenosis in proximal left anterior descending artery. And patient was stented and discharged with pain-free condition. There is two patterns of valence. Type A, biphasic T with initial positivity and terminal negativity. Type B, deeply and symmetrically inverted T. Our patient has features of type A. There are some diagnostic criteria of Wieland syndrome. Deeply inverted or biphasic T waves in V2 to V3 may extend to V1 to V6. Isoelectric or minimally elevated ST segment less than 1 millimeter. No pathological Q waves, preserved precordial R wave progression, recent history of angina, ECG pattern present in pain-free state, normal or slightly elevated serum cardiac markers. What are the clinical significance of this ECG? It is highly specific for a critical stenosis of the left anterior descending artery. It is a high risk for the development of extensive anterior wall myocardial infarction within the few next days to weeks. Early coronary angiogram and revascularization should be done. Patient may suffer from myocardial infarction or cardiac arrest if attempted for any stress test.
Shahana.
Sir.
Whether the ECG changes is reversible, that is what changes happened after the PCI.
Yes, sir. আমি আসলে খুব সরি যে আমি আফটার পিসিআই যে ইসিজিটা সেটা আমি সংগ্রহ করতে পারি নাই, দেখাতে পারছি না, কিন্তু এটা রিভার্সিবল স্যার।
স্যার একটা কোয়েরি ছিল স্যার। সেটা হচ্ছে আমরা যারা জুনিয়র বা ঢাকার বাইরে বা ক্যাথল্যাব ফ্যাসিলিটি নাই এরকম জায়গা থেকে যখন এই পেশেন্টগুলো আসবে, তখন তাদের ক্ষেত্রে লো মলিকুলার হেপারিন কি এই পেশেন্টগুলোকে দেওয়াটা যাবে কিনা স্যার, জাস্টিফাইড হবে কিনা, এবং তাদের ক্ষেত্রে সেই জায়গাটাতে কি হবে? কারণ আমরা অনেক পেশেন্টই পাই ঢাকার বাইরে বা এমন সেন্টারে যেখান থেকে কাছাকাছি ক্যাথল্যাব ফ্যাসিলিটি জায়গাও নাই অথবা নাই, সেই জায়গাগুলোতে স্যার।
তুষার, এই জন্যই বলছিলাম অ্যাগ্রেসিভ মেডিকেল ম্যানেজমেন্ট ইজ ইন্ডিকেটেড, এবং তুমি যত তাড়াতাড়ি সম্ভব তাকে ক্যাথেটারাইজেশন করার ব্যবস্থা করবে। আমাদের দেশে প্রেক্ষাপটে আমি সরাসরি ক্যাথলেবে নেওয়ার কথা বলতে পারি না, কিন্তু অ্যাগ্রেসিভ ম্যানেজমেন্ট শুড বি দেয়ার।
And to add with that, Wadud, aggressive should include dual antiplatelet and yes, heparin. Absolutely. I would give full dose heparin if if we are anticipating the cath procedure within 4 hours, then I usually like to give heparin. But if it is a logistic issue, then you can give 1 milligram per kilo enoxaparin. There are actually some suggestion of giving enoxaparin even IV, but at least you can give sub-Q 1 milligram per kilo.
Actually, ECGটা শাহানা আমি খুব ইম্পর্টেন্স দিই শাহানা যে এটা দেখাও, কারণ এই পেশেন্টগুলো এক সপ্তাহ পরে ফুল এমআই নিয়ে হার্ট ফেলিওর নিয়ে তারপরে কিন্তু আমাদের কাছে আবার প্রেজেন্ট দিয়ে দেওয়া হয়, অল্প একটু ওষুধ দিয়ে তাদেরকে অ্যাগ্রেসিভ ট্রিটমেন্ট দেওয়া হয় না, ডুয়েল অ্যান্টিপ্লেট হয়তো দেওয়া হচ্ছে কিন্তু বাকি সব জিনিস ব্যাখ্যা করা হয় না, এবং এই পেশেন্টগুলো সাফার করে দে লস্ট দ্য মাইন্ড হুইচ শুড দেয়ার।
মেজরিটি কেসে স্যার আমরা পাই যে লো মলিকুলার হেপারিন অথবা হেপারিন না দিয়ে পেশেন্টগুলো আসে আমাদের কাছে এনআইসিভিডি তে।
আচ্ছা, কেস 2 দেখাও, এটাও সুন্দর কেস দেখাও।
50 years old, diabetic, who is a normotensive and non-smoker, hailing from Chowdhury, admitted with chest pain for 10 hours. On examination, his pulse was 42 beat per minute, but regular, BP 90/60. It was his admission ECG which showed ST elevation in lead 2-3 AVF, and he had features of complete heart block with ventricular rate of 42 beat per minute. Right-sided ECG was done, and where we found ST elevation in V3 to V6 and tall R and horizontal ST depression in V1. And we diagnosed this patient as acute ST elevation myocardial infarction inferior with posterior extension with RV infarction with complete heart block. A temporary pacemaker was implanted immediately, and then patient was thrombolized with streptokinase. After thrombolized, ECG showed paced QRS complex interrupted by normal sinus QRS complexes. Complete heart block improved, but type 1 second degree AV block developed. Third day after admission, ECG shows type 1 second degree AV block, but on the same day, patient developed 2:1 AV block. 10 days after admission, patient AV block is reverted, but only first degree AV block remained. Now, what should be further management plan for this patient?
Can you go back to the first ECG, please? So, what was your comment about this ECG?
Acute inferior myocardial infarction.
But okay, but the problem is
LBB.
Patient has bundle branch block type pattern, either a ventricular escape beat or left bundle pattern. But can you go to the next ECG, please? This one is different now.
Yes.
Because this inferior lead shows the ST elevation with a narrow QRS, which is probably a junctional rhythm with conducted QRS. This shows the inferior ST elevation. So any comment from any of the faculty that can we take the first ECG as a diagnosis of acute inferior myocardial infarction if we didn't know the history of this patient?
No, sir. Hey, Wadud bhai.
No, we could not say that. As Sir was mentioning, that was the case, LBBB pattern, bundle branch block pattern, with complete heart block. And now the history of chest pain is suggestive there is something amiss.
But the next ECG is very clear, because the next ECG is a junctional narrow QRS and clearly ST elevation in inferior leads. Thank you.
So the TB, as I say always, that is two part: ST elevation part and the MI part. The patient is clinically behaving like MI, and then EKG is showing left bundle pattern morphology, but there is, can you invoke Garbosa? Probably not, but overall the coexistence of the heart block and then the clinical story, I would not even doubt that this is not a STEMI.
Yeah, I mean, Hafiz, you are making a valid point that we have been talking about this for last 3 sessions, that
Yes.
the clinical scenario, I mean, the most important part is the clinical scenario of the patient.
Yeah.
And make a judgment based on that. That's important. So I think our young doctors who are there, please remember the patient. ECG is just one of the modalities or any investigation, whatever it is, but the patient symptom is the most important part that we have to emphasize on.
Can
Thank
I add something? This patient has LBBB morphology, but the T wave is upright in laterals, in 1, in LVL, and also the 5-6. That's how there is ischemic origin. And that's also helpful regarding that this could be an estimate. Though we could not be sure which arterial territory is involved. This has been told before. Garbosa can take
And then this is actually, Rafiq Bhai, what do you call this? This is actually a complete heart block and escape rhythm, right?
escape rhythm. Shahana, proceed. Sir, the Shahana's question was, what should be the management plan when the patient has first-degree AV block?
Does this patient need permanent pacing?
Atahar Bhai, your comment.
No, Shahana, actually the AV block has improved. It was initially complete heart block, now it is just first degree heart block with narrow QRS, conducted beat at the narrow QRS. So there is no indication of the permanent pacing at this point. The patient should undergo the coronary angiogram and revascularization first. That is, we should to take care of the coronary first.
Thank you, sir. Thank you for sir expert opinion. I want to go the next ECG. May I?
Is it the number 3?
Yes, sir.
So any comment about the previous ECG, Rafiq sir?
Yes, sir is perhaps not there.
Hafiz bhai?
Say that again?
The previous is the management plan about the complete heart block, and then now finally the patient has the first degree AV block.
So management, at what point? Because during the time of MI and then transfer, cath lab, temporary wire, PCI, reperfusion, but looks like this is little late. The question is, from the electrical point of view, patient is okay, first degree AV block, as you pointed out. But the question is, what do you do about the revascularization?
Yes.
So now this is 3 days post. Patient falls into probably the Wadud trial, no chest pain, stable, right? So what is the benefit further? Very little benefit probably at this point to open the artery, although if we take to the cath lab, you try to open, but if it is that late and if there is no active ischemia, post-infarct angina or arrhythmias, then there is hardly any benefit, and we know from the Wadud trial. So I don't know how did you manage, but it will be interesting to know how did you manage.
Shahana, elaborate.
Sir, regarding management of previous patient, sir, patient has discharged for the advice about the coronary angiogram thereafter, because there is no facilities for the coronary angiogram to that condition that time, because patient is scarcity of money, constraints of financial constraint was there.
And actually that's reasonable, because in the past in Europe, in 80s, they were doing this low level modified Bruce protocol following lytics and see whether there is any residual ischemia. If there is no residual ischemia, inferior, relatively young, prognosis actually overall not bad following the lytics. But hopefully you will be doing all the aggressive risk factor modifications and follow up.
Shahana, into case 3.
X, 58 years old, who is diabetic, hypertensive, and who has a history of stroke, present with severe central chest pain for 1 day. Her pulse was 124 beat per minute, BP 120 by 60 millimeter mercury. It was her admission ECG, which showed extensive anterior myocardial infarction with left anterior fascicular block. As the patient presented late in the hospital, she could not be thrombolized and was being managed medically with low molecular weight heparin and other anti-ischemic drug. But 5 days later, the patient developed severe bradycardia with hemodynamic compromise. ECG showed high-grade AV block, and then patient was not responded to injection atropine. That's why temporary pacemaker was implanted. After implantation of temporary pacemaker, we have done ECG next day, and we found a patient reverted to the sinus rhythm with
Bifascicular block.
Bifascicular block. TPM was withdrawn 5 days after its implantation, but patient did not improve clinically, rather deteriorated. 12 days later, as the patient was deteriorated, we examined the patient thoroughly and find a systolic murmur, and patient was sent to echo lab and found there is a ventricular septal rupture in the apical part. And we sought surgical consultation, and they asked for refer the patient after when patient is hemodynamically stable. But with all our limited resources, we can't survive the patient, and patient was died after 14 days after admission. Now my question, whether pacing can improve mortality if there is extensive myocardial damage?
Well, can I make a comment?
Yes.
I mean, this patient came with an anterolateral myocardial infarction. I mean, before we talk about pacing in this patient, we should have talked about the cardiac catheterization.
Yes.
I don't believe, I know NICVD, I know there are free stents available. Even if the patients are poor, I know this is not I'm sorry to say this, I don't normally discuss this kind of issue, but I know that at NICVD, there are stents which expire without being used. I know at NICVD, pacemakers expire without being used. And we can blame each other or everybody, including all the politicians in the world. But ultimately, we are the physicians who are responsible. I mean, this patient, unfortunately, she should have got a cardiac cath in the beginning before discussing this pacemaker issue.
Sir, can I add another question? Was the TPM somehow responsible for the VSR in the apical?
The septal, this perforation looks like in the septum, right?
Yes.
It is unlikely that a temporary pacing catheter will cause septal perforation. I think this is related to the acute myocarditis, unless Hafiz have any other comment. I think.
So Rafiq bhai, this is this apical septum. If you are showing me anterolateral and then apical septum, and this is delayed and non-reperfused MI, this is post-MI.
Yes.
The post-MI VSD, apical VSD, these are actually relatively is easier for the surgeon to repair, but we, the interventionalists, know that how the surgeons feel. They say hemodynamically stable. The problem is you will not be able to get hemodynamically stable as they want. So at some point you need to decide, because if the patient is on pressures lower dose, you put a intra-aortic balloon pump put a swan in and convince them that it is not as bad as they think, and then do something. Because the alternative of not treating, the mortality is very high, as unfortunately in this case happened. So it depends on your surgeon that whether they will take it or not.
But Hafiz, I'll tell you, if I'm a surgeon and you send this patient to me without a cardiac catheterization, without knowing the coronaries, you will have to put a gun on my head. Even then, I will refuse.
No, Rovik bhai, no. We don't do that. Hey, I got this, Timmy. So no, Rovik bhai. This is first, the intervention is to take to the cath lab. There is no question about it.
Exactly, that's what I'm saying.
Coronary angiogram, right heart cath, left heart cath, and then put a balloon pump, and then give it to the surgeon after that. Even after doing that, we struggle here, because what happened that, and we know the coronary anatomy, the posterior medial pap muscle and the anterolateral, and then the exclusive supply. So the right coronary is more to give to the VSD, and those the basal septal VSDs, spiral issues, difficult to repair by the surgeons because mitral valve is closed. Sometimes they end up with affecting the mitral valve as well. But in the case of anterior apical, these are all two things. If it is very sick, they will say to that interventionalist, why don't you close with amp larger device? I've done one, but it is very difficult to oppose these devices because you have to do cumbersome process, and the tissues are their problem, we have problem, because the tissue is necrotic tissue. You cannot anchor the device very well. But they do have the same problem, but patch repair for the VSD apical, this is easier than the posterobasal septum that we see in the inferior. So sometimes they say, okay, if the pressures are too high and the right heart pressure also bad and patient pulmonary edema, they say, okay, chill a little bit. I can see that because it is, if a couple of days, balloon pump, we heal the tissue, but no surgery is not a good option.
Hafiz bhai, sir, yeah. Rafi sir, the question Shahana was posing, let us say this patient did not develop the PSA, and yes, we have to go for the revascularization after CAP. But what about the conduction abnormality issue?
Yes, I mean, this is anterior circulation, and most of the time, this is permanent. I was surprised to see that the conduction came back.
Yes.
But so if the conduction comes back, then we can observe, but we have to be very, very careful about this group of patients. I mean, if somebody had this patient and let's say you have revascularized, let's look at the ideal scenario. You put a stent and the conduction has come back. What I would probably do, look at the conduction system in the EP lab. If I find that the HV interval is good, if I do rapid atrial pacing, there is 1-to-1 conduction to a rate of 100, 120 beats per minute, then I can tell the patient, you'll be fine. But this was surprising, it came back. Normally they don't come back that well. And the question was the mortality, right?
Yes, sir.
You see, there is no data that pacemaker decreases mortality. We have no data showing that in any situation, because most of the pacemakers are put in for 600 syndrome. And of course, people with complete heart block, there is no study to show that.
Shahana, bolo.
Conduction abnormalities related to the acute myocardial infarction. In inferior MI, it usually involves active ventricular node, but in case of anterior MI, it involves infranodal structures like bundle branches and fascicles. First degree AV block, Mobis type 1 AV block, complete heart block are common in case of inferior MI. Mobis type 2 block, bundle branch, fascicular blocks are common in case of anterior MI. In case of inferior MI, escape rhythm is AV, junctional, and it is narrow QRS complex. But in case of anterior MI, escape rhythm is ventricular, so wide QRS complex. Inferior MI, the rhythm abnormality is usually reversible, but in case of anterior MI, it indicates extensive myocardial damage and is usually progressive and poor prognosis. In case of inferior MI, mortality is low, and anterior MI, its mortality is high. May I proceed regarding the indication of temporary and permanent pacing in case of acute myocardial infarction, or I'll go for the next case?
এটা একটু রিক্যাপ করে নিই।
better for a participant.
Okay. Indication for temporary pacing in acute myocardial infarction: medically refractory symptomatic sinus node dysfunction, Mobis type 2 AV block with acute anterior infarction, third degree AV block with anterior infarction, new bifascicular block, alternating bundle branch block, new bundle branch block with anterior infarction, bundle branch block with indeterminate age with anterior or indeterminate location infarct, medically refractory AV block with bradycardia and symptoms regardless of infarct location. Now, recommendation for permanent pacing after acute phase of myocardial infarction. Class 1 indications are: permanent pacing is indicated for persistent second degree or third degree AV block in the His-Purkinje system with alternating bundle branch block. Then there is transient AV, advanced second or third degree infraneural AV block and associated bundle branch block, and last, persistent and symptomatic second or third degree AV block. And there is no 2A indication, but there are some 2B indication like permanent ventricular pacing may be considered for persistent second degree or third degree AV block at the AV node level, even in absence of symptoms. And contraindication for the permanent pacemaker in acute myocardial infarctions are: transient AV block in absence of intraventricular conduction defect, transient AV block in presence of isolated left anterior fascicular block, new bundle branch block or fascicular block in the absence of AV block, persistent asymptomatic first degree AV block in the presence of bundle branch or fascicular block.
আমার মনে হয় আজকে রফিক স্যার দেখাবেন না স্যার? রফিক স্যার কি দেখাবেন?
হ্যাঁ দেখাবো, বাট এগুলো তো ভালো কেস তো এগুলা
স্যার। ও খুব সুন্দর সুন্দর কেস দিয়েছে।
No, let's look at these cases because these are important cases, so we should look at it, and then I'll show some ECGs when she's done, when Shahana's done.
4 নম্বর বলো, চলে শাহানা প্রসিড।
Mr. S, who is 35 years, non-diabetic, normotensive.
শাহানা, তোমার কথা শোনা যাচ্ছে না।
Mr. H, who is, am I audible now?
Yes.
Mr. S, who is 35 years old, who is non-diabetic, normotensive, came to cardiac emergency with the complaints of palpitation for 2 days and chest discomfort for 1 day. He had history of same attack before, and he was hemodynamically stable, and he had a 12 lead ECG done outside the hospital. This is 12 lead ECG which has been done outside the hospital, where we show that rhythm is irregular, rate is about 170 per minute, P wave absent, right axis deviation, and whether it is they are designated as Q wave in lead 1 and AVL, and there is a poor progression of R wave in the chest lead. In emergency, patient was diagnosed as a case of high lateral myocardial infarction with atrial fibrillation with fast ventricular rate, and for this he was treated with antiplatelet, antilipid, nitroglycerin, beta blocker, and anticoagulant. We have done ECG again and focused on the ECG findings, and we differ from the emergency management, differ in opinion regarding the emergency management. First of all, rate is irregular and a negative QRS in 1 and AVL. Then there is progression of R wave is abnormal in V1 to V6. And now my questions towards the expert panelist: what should be diagnosis to see this ECG.
Shahana, did you do the physical examination of this patient?
স্যার আমি আসলে এটা ব্যাপারে বলতে চাচ্ছি না, পরে বলতে চাচ্ছি, পরে বলবো।
এই
What is the question, Atahar bhai? What is the question?
Now, I want to know the physical findings.
Oh, okay.
Is there any other ECG before this one?
No, this same type ECG which was done outside the hospital. ECG is same.
Two transfer, we say.
Yeah, I'm just curious about the lead 1 and AVL. I mean,
Yes,
did
sir.
we ever consider lead swap?
There's something wrong with the leads.
Most likely, sir. Most likely,
Because-
sir. The list was this reversed.
Because if you lead and 1 and AVL, there is so big Q wave. In V6, V5, there is nothing.
Yes.
sir.
So that's a little unusual.
And there is no positive deflection in either of the leads. Sir.
Exactly.
Sir, can I make a comment?
Yeah, please.
If Q wave in 1 AVL, I should be looking for Q waves in 5-6, or I should be looking for tall R in V1, V2. There should be either anterolateral or posterolateral involvement.
Yes, absolutely.
And
May I proceed, sir?
proceed.
Then what should be our diagnosis? Our options are lateral ischemia or myocardial infarction, whether it is dextrocardia, but here AVR is negative. Then whether it is dextro position or there is incorrect lead placement.
Last two should be taken into consideration.
Immediate investigation done, and troponin I was negative, and other blood sugar, serum electrolytes and creatinine were normal. Next day ECG, patient reverted to sinus rhythm. QRS is inverted in 1 AVL. AVR, regarding AVR, I want to take opinion from the expert faculties, but my diagnosis was sinus rhythm with dextrocardia, but whether it is true dextrocardia or technical dextrocardia, in V1 and V6, we see here reverse progression of the R wave, and we take this as the true dextrocardia. Now, my comment regarding AVR, whether this AVR is upright or is AVR is negative.
It's a positive P wave.
Rofik, sir.
There is positive P wave.
Regarding pectoral leads, otherwise regarding pectoral leads, what she said, I do differ with that, as because in lead 1 is normal RS pattern, and in V5, V6 also, though it's not too tall, gradually it rises up and the transition is shifted towards right. But it's difficult to say that this pattern does not fit with the true dextrocardia.
I said it's a fit with the true dextrocardia. I said it's fit with the true dextrocardia. It's the reverse progression.
How?
Okay, can
How
I make a
reverse
comment?
position?
Can I make a comment?
Yes, sir.
What Jamil said is absolutely. If you look at lead V1, there is, I'm just looking at R and S pattern. If you look at V6, even though it is small, but if you just magnify this ECG, it will look perfectly normal progression.
Yes, sir.
So I don't think this fits in with the pattern of true dextrocardia. And also, if you look at like V5, you see V5 if it was true dextrocardia, by V5 the R would have been much smaller. It is not.
Again, sir, in lead
Unless
V1,
you are surprised
would
for
be
us,
there.
you have the chest X-ray.
তুষার বোরহানুদ্দিন রেজ হ্যান্ড করছে, ওকে একটু কথা বলতে দাও।
ওকে
Burhanuddin.
Burhanuddin. Burhanuddin সাহেব আপনি
ভিডিও অন করতে
Burhanuddin আপনি
আনমিউট
unmute
করতে
করেন। Dr. Burhanuddin আপনি unmute please. Dr. Burhanuddin unmute please.
আনমিউট রিভুকে করতে হবে, রিভু আনমিউট করো। ডক্টর বুরহানুদ্দিন।
This patient is only 30 years old.
To me, it looks like dextrocardia because the transition is, look at the voltage that changes from the V to the V4 onward. So that raises question, and then you look at lead 1, so then it goes in favor. Like it does not, definitely it is not the limb lead transposition. It is not. So I would be very interested to know where is the apex of the patient.
Yes, that's why
May I proceed, sir?
asking.
May I proceed?
Yes, please.
Okay.
By the way, dextrocardia patients are allowed to have MI.
Yes, this is the
But-
chest
but-
X-ray of this patient.
Yeah, this is 30-year-old. It is very difficult to say that this is mine, but I need to know the clinical context.
For the youngsters, this is very important. Look at the patient age. At 30 years of age, you are not supposed to have a big MI. You are not supposed, you may have, at least in this country. But, and that's the reason we should be thinking of other diagnoses, including the diagnosis of dextrocardia and other things.
Chest X-ray post-interview revealed dextrocardia, echocardiography, ultrasonography of the abdomen also support that diagnosis, and our final diagnosis was dextrocardia with paroxysmal atrial fibrillation.
One thing I request you to, if you say that this is not dextrocardia, but it is the lead transposition, if you don't diagnose that, don't read the STT changes if the leads are changed, because then you may be in trouble. So get these right, then read it.
Exactly, that's the point.
And actually, this is more fits with the mesocardia, where the apex and face towards the sternum.
জামিল ভাই এই কনজেনিটাল হার্টে বেশি দূর যায় না, মাথার ডিজি।
Shahana, very good. Yeah.
Excellent.
May I proceed? Next case, only 5 minutes.
Shahana, what is the cause of low voltage of the previous patient? Did
Sir,
you
I
get
don't
any
know.
finding?
I don't know, sir. No, sir. But not further any investigation was done. Patient was discharged. I did not find any other documentation.
Atahar bhai, I would not read low voltage because in the precordial leads not bad. Limb leads not bad, and the precordial leads in the presence of dextrocardia. Remember, you have to read all leads in the precordium low voltage, not 5.
Exactly. V1 is not low voltage, right?
Yeah.
My next case and last case, Mrs. Y, who is 62 years, came to cardiac emergency with the complaints of chest pain and palpitation for 6 hours, drowsiness for 7 hours, and recurrent episode of vomiting for several days. Her risk factors were hypertension and diabetes. On examination, her pulse was 72 beat per minute, BP was 130 by 80 millimeter of mercury. Her precordial and lung examinations were normal. This was her admission ECG, which shows ventricular bigeminy. Then, but ECG has a dynamic change, and where we found that rate is 80 per minute, rhythm regular, and he has increased QT interval, and which is about corrected QT interval was 693 millisecond. but patient suddenly developed wide BZR irregular QRS complex with changing amplitude from upright to inverted position, and rate was or about 250 per minute. PO was absent, and our diagnosis was torsades de pointis.
What was like?
Biochemical examination showed her creatinine was 1.5, her potassium was 1.5, and sodium was 126.
Yeah, classical.
Our final diagnosis was torsades pointis with long QT due to hypokalemia with diabetes mellitus with hypertension.
But why the vomiting initially? That should be put into diagnosis. Was it gastritis or cholecystitis or pancreatitis or simple peptic ulcer exacerbation?
Maybe simple peptic ulcer exacerbation, but we don't know the definite cause of vomiting of this patient.
Next.
Our management given for this patient was DC cardioversion with injectable potassium and magnesium, tablet sodium chloride. We think as a resident asked whether he will give amiodarone, then we think whether we can give amiodarone for this patient. Amiodarone is a class 3 antiarrhythmic that prolongs QTc and is contraindicated in case of long QT and torsades de pointis. And then after cardioversion, a patient is reverted to sinus rhythm, but QT is still prolonged. And for this patient, we plan for temporary pacemaker. And why temporary pacemaker for this patient? Temporary pacemaker around 100 beats per minute prevent the short-term recurrence of the torsades associated with both acquired and congenital form of long QT. The cardiac pacing prevents pauses and shortens the QTc interval by enhancing the repolarizing potassium currents as a result of increased heart rates. TPM should be placed if intravenous magnesium therapy fails to prevent the recurrence of the torsades. TPM is effective in preventing the recurrence of torsades irrespective of the baseline heart rate. It has particular value in bradycardia or pauses. Magnesium is effective for suppression of the short-term recurrences of the torsades and is the agent for the immediate treatment of the torsades associated with long QT irrespective of the serum magnesium level. Mode of action is not clear but may be mediated by blockade of sodium currents. Potassium is an important adjunct to the intravenous magnesium therapy for the short-term prevention of the torsades, especially when serum potassium level low. 2015 European Resuscitation Council guidelines showed the maximum recommended IV dose of potassium is 20 millimole per hour, but in case of unstable cardiac arrhythmia, when cardiac arrest is imminent, more rapid infusion is indicated. This is ECG after correction of hypokalemia and withdrawal of temporary pacemaker, and we found here rate is about 100 beat per minute, rhythm regular, and with QTc is about 36 millisecond.
Shahana, can you go back? After magnesium and potassium supplementation, what was the QT?
So QT prolonged after DC cardioversion, potassium, magnesium injectable. This is the ECG.
At discharge, what was the QT level? QT. Last ECG.
Yes, this is the QT is about 36 millisecond.
Still the QT is prolonged. No. It's 360, no?
That's borderline less than 50% of the RR interval.
The absolute value is
It's not less than 50%. Otherwise, it's more than 50% of the RR interval.
No, but the rate is high. Corrected QT.
Corrected 360. Yeah.
Next.
However, improving.
Next.
My take-home message: predictor of critical left anterior descending artery stenosis predictor of critical LED stenosis deserve early invasive therapy. Complete heart block in inferior MI is more common, which is about 14%, affect every node and usually reversible. Complete heart block in anterior MI is less common, which is about 2%, and involve infranodal structure, indicates extensive area of myocardial damage and has a poor prognosis. Some rare condition can mislead patient's treatment, so meticulous observation of ECG is important. TPM is effective in preventing the recurrence of torsade disc irrespective of the baseline heart rate when IV magnesium fails. Thank you. Thank you for giving me attention, sir.
Thank you very much.
রফিক স্যার আছেন?
Shahana, excellent job.
স্যার খুব সুন্দর চয়েস হয়েছে না স্যার?
আর তুমি তো আমাদের জুনিয়র, তোমাকে একটু গ্রিল করলে আমাদের ভালো লাগে। But you did a great job. This is good. This is wonderful. Shahana, always good. Very thorough. Good.
স্যার রফিক স্যার আসসালামু আলাইকুম।
Awesome.
স্যার একটা কোশ্চেন ছিল স্যার, এটা হচ্ছে কিছু কিছু ক্ষেত্রে আমরা লং কিউটির কোনো কারণ খুঁজে পাই না অনেক সময়, তো এই পেশেন্ট গুলোকে আমরা যখন ছুটি দেই, ড্রাগ ম্যানেজমেন্ট দিতে যে উই বিকাম ভেরি মাচ ফিয়ারফুল। What to do in that case?
Shahana, can you go back in the ECG with the torsade, please? So, this is a fairly ugly looking ECG. This was in telemetry?
Yes. Yes, sir.
Yeah, I mean, it's tough to make anything out of this ECG, actually. And the patient was conscious or unconscious?
Patient was acute confusional state.
And what is the potassium?
1.5, sir.
5.
1.5.
1.5. Yeah, that's very low. I have seen lowest I've seen is 1.7. So did you find out why the potassium was low?
Repeated vomiting.
The patient has repeated history of vomiting for 2 days.
Yeah.
But cause of vomiting, I don't know.
Yeah.
So probably severe hyponatremic alkalosis and hypokalemia. So so we need to supplement both all along with magnesium.
Yes,
Do you give magnesium as well?
Yes.
Yeah. So two things. One, I'll come to Tushar's question. First of all, so far I have seen 3 patients. One had a potassium of 2, came with VF arrest. Second patient, potassium was 1.7. It was very unusual. He presented with ventricular tachycardia. And the first patient, what we found out that he had potassium losing nephropathy. And the question was whether to put a defibrillator in that patient or not. We did not. And a patient did fine. I mean, the only problem in that scenario would have been that if the patient does not maintain adequate therapy and then goes to hypokalemia again. So this is the problem. In this one, of course, we have a cause of hypokalemia, but still in potassium of 1.5 is very low. Even though we are thinking this is due to vomiting, we need to rule out other causes of potassium loss. Like maybe patient has a potassium losing nephropathy on the top of that developed vomiting and became so low. And this is not a long QT syndrome because at that heart rate, it will be very, very difficult to assess the QT interval. To answer to Tushar's question that how to decide management, I mean, of course, this is a complex field now. And if you put an ICD in an adrenergic dependent long QT syndrome, you will end up multiple shocks. So those patients should be treated with beta blockers. I think carefully looking at the baseline EKG to find out if we can pinpoint without genetic testing what type long QT it is, and then decide on medical treatment. And the thing that's happening in the genetics and the molecular field that they are coming up with all different types of these genetic abnormalities and trying to pinpoint treatment. And I think it will take a few years before this happens. I remember at Heart Foundation many years ago, I saw this young girl who had a long QT and went to India, had a defibrillator put in. And I don't blame the physician for putting it in, but that poor girl received like 100 shock in 2 days and battery depleted. And what happened in that scenario, that every time she gets shocked, she has more adrenaline in the circulation. And it was adrenaline dependent problem, and just ended up depleting the battery of the defibrillator. That patient should have been treated with beta blocker. But now we know that that was in early 2000. So there is no clear answer to that.
I like to add something that elderly diabetic females has potassium losing nephropathy, and cause is not exactly determined, along with magnesium depletion. It's quite common. There is an article published from Bardem in their journal.
The other thing, with a heart rate of around 100, I am not sure I would have put a temporary pacemaker in, because we know the cause. The potassium was low. I'll supplement the potassium, because beyond, I mean, if you put, normally what we do is that if somebody has heart rate of 40 or 50, and we put a temporary pacemaker for a few days until the heart rate comes up or the underlying cause is resolved. This heart rate was pretty fast, about 100. So, all right, but we need to bring Shahana back again.
Yes.
She is thorough.
Shahana, can you hear?
Yes, sir.
These cases are from, as I was saying, she should be showing some real life case scenarios where there are dilemmas, there are problems. She has done something and find out the solution and presented the whole scenario and the evidence very nicely with theoretical background. Shahana, well done. Unshare, please.
Thank you.
Stop sharing.
Thank you, Shahana.
স্যার আপনি দেখান। ডক্টর বোরহানুদ্দিন একটা কোশ্চেন করতে চাইছিল, সেটা কিন্তু বলেনি।
Why didn't you ask him to give the question?
তুমি একটু আনমিউট করে ইয়েটা ক্যামেরা করে একটু কথা বলো। ডক্টর বোরহান, আর ইউ দেয়ার?
আচ্ছা তুষার
স্যার,
বোরহানকে একটা ওই যে চ্যাট করো, মানে
স্যার আমরা অ্যাড করেছি।
আছে তো?
আচ্ছা আছে স্যার, আমরা বাট তার আনমিউট এবং ভিডিও অফ করা আছে। ডক্টর বোরহানুদ্দিন আহমেদ, আপনি কাইন্ডলি যদি আনমিউট করেন।
ঠিক আছে স্যার, প্রসিড করুন।
স্যার নেটে একটু ঝামেলা হচ্ছে হয়তো।
Fine. So Shahana showed, this is the patient that I did cardioversion recently, and this is the post-cardioversion ECG. I just added it. I thought it will be curious. Oh, sorry. So what do you think? We have the poll, right?
Sir, I'm starting the poll now then.
রিভিউ পোল দাও।
হয়তো আমি একটা মিটিং আছে, পরে ফোন করতে। Okay. So I think at least there is no A and B answer. So this is this is dextrocardia. I mean, what Jamil and I was talking about, that if you look at this patient, lead 1 is inverted, AVL, so it looks like limb lead swap. However, in V1 through V6, and this was properly placed V6 lead, and this patient actually had dextrocardia. So I wonder if Shahana, the ECG that Shahana showed, the person knew that the patient has dextrocardia, put the chest lead in the right place. And this is the same patient with when I put the right-sided chest lead. See, so we did not swap the limb leads. Limb leads looks as if there is limb lead misplacement. However, now we can see the R wave in V6. So this was a patient with dextrocardia. So please remember it. So every time we see a limb lead swap, we have to look at the chest lead, make sure that this is not dextrocardia. But you know, these are not a lot of cases. A lot of times the patients will tell the doctor, hey, doctor, listen on the other side. So I have this ECG. I decided that
In case of dextrocardia, lead 1, what will be the P? P will be upright?
Oh, no. Dextrocardia, lead 1, P will be inverted. Because what's happening, lead 1 is a left arm lead. And normally, the electricity goes from the right to left side. In dextrocardia, the sinus node is on the left side and it is moving from left to the right. So lead 1 becomes negative.
So because this is a tough one, because it is a very tough one, because it is if you look at the precordial leads, you see dextrocardia. Then you get confused that this is a limb lead, but overall, still you have to think about dextrocardia here.
So the trick to it is that if you think there is limb lead swap, but there is reverse progression of the V1 through V6 in a properly placed EKG, then you think of dextrocardia.
Right.
But if I had this ECG without VR marking, you will probably just think of limb lead swap. Here I have put the marking that is a V1 right-sided lead. So that is marked that this is a right-sided lead. So,
can I say something with this ECG? I'm Dr. Naruma, sir, from pediatric cardiology, sir.
Yes.
Sir, this from lead 1 is P negative and ABR is lead P is positive. So
yes.
That situs inverses, and from chest lead, there is progression of the R wave. So there is levocardia. So it can be a complex one that situs inverses with levocardia. Sir, can it be?
Oh, the one that I'm showing now, these are right-sided chest lead.
Yes, sir. Yes, sir.
So this is the
situs inversus means atrial inversus, and there is levocardia, because there is in V1 to V6 there is progression of the R wave, and E wave in lead 1 it is negative and AVR it is positive. So
this is the original ECG.
It was ECG because this is a created problem. Sir has put the limb leads as it is, but the chest lead he put it on the right side.
Exactly. So in this ECG, I did not change the limb lead.
Sir, but if you give without any clue to me with this ECG,
yes,
I give the impression that here it is atrial inversus. That means left atrium is in right side, means sinus node in opposite direction. So from atrial it is inversus. If you give me only this ECG, sir.
Okay. So if you gave me this ECG without telling me that this is a right-sided chest lead.
Yes, sir.
As an adult cardiologist, we will just think of limb lead swap.
Yes, sir.
And we'll first confirm, right, Wadud? We all will do that, right?
Exactly.
Yeah. And then we'll just, first thing we're going to confirm that leads are in light place. I'm going to get a second ECG to make sure.
I'm trying to understand her argument that even if it is, even if we don't tell the VR, V5R, V6R, you will still be able to diagnose this as dextrocardia? What will be the points in favor?
Sir, I will not tell it that apex is in the right side. I will tell here that the apex is in left side. That means levocardia. But from the P wave in lead 1 and AVR, I will comment, sir, situs means atrial situs inversus.
Sir, can you bring the first ECG, sir, first?
Yeah.
Acha, Naharma, are you commenting about this ECG?
No, sir. Not this ECG. Second one, sir.
Yeah. So, I mean, this, from adult cardiology standpoint, we cannot think that complex. I mean, this ECG for all our adult cardiologists, we will just think of limb lead swab if you did not tell me that the chest leads are right-sided. And we are going to repeat the EKG to confirm that.
রফিক স্যার আমি একটা প্রশ্ন করতে পারি?
Yes, sure.
স্যার ওই যে আমরা তো লেফট সাইডের লিডটা আপনি রাইট সাইডে নিলেন, আপনি হোয়াট অ্যাবাউট আপনি লেফট আর্মটা রাইট আর্মটা লেফট আর্ম নেওয়াটা উচিত ছিল কিনা, আমরা নেওয়া উচিত কিনা?
The question is, when the technician did this ECG, she asked me this question. Right. But I told her not to do that. Because if we change the lead, are you going to change the leg lead also? And once you do that, you will have no clue at all. So if I change right arm, left arm, right leg, left leg, this ECG, even with if you did not make this thing, you would be totally normal ECG. It will look like normal ECG. You will have no clue at all. So you're right. I mean, the question would be, shall we? I mean, if you want to be idealist, of course you will have to swap the lead. If you, in that patient, if you want to represent a normal ECG, then you will have to swap the right arm, right leg, right arm, left arm, and left leg, right leg. Yes, absolutely right. And that will make it a perfectly normal ECG.
And you will completely confuse the people.
I'm not confusing the people. Actually, what you see when you think it is a dextrocardia or it is a reverse arm ECG, sometimes you need to change your limb lead also, so that you make sure to compare the previous one. Yes, it is definitely dextrocardia.
Ajam, no question about it. No, let's forget about this. Let's say you want to compare the lateral lead, right? And if you want to do that, then you will have to swap the limb leads. In this particular patient, if this patient was coming with a lateral MI, and I want to see ST elevation in lead 1 AVL, we will have to swap 1 and 2. I mean, lead right arm, left arm, no question about it. So anyway, luckily these are not frequent cases, and this patient actually told me, Dr. Ahmed, my heart is on the other side, because he was not my patient. And I was doing cardioversion.
Adult congenital heart.
Okay, so today's theme is very simple theme. So I want majority of the people to answer. Please do answer these questions. Is the poll over? Okay. Not many people answering. I put two things very close. One was sinus rhythm rate 90 beats per minute, and then sinus rhythm rate 66 beats per minute. 36% counted the rate as 90. And well, I mean, this is what multiple choice question is all about, that you can always choose something that you find convenient. So I think I'd request that you pay attention. This rate was nowhere near 90. The C, and then Wadud, can you comment on the answer D, which is sinus rhythm with old inferior myocardial infarction? One person said old inferior myocardial infarction. Is Wadud still with us?
Regarding MI, has been always emphasized. You cannot diagnose MI on the basis of a single lead. If you have a Q in lead 3, which can be a very normal finding, Q normally can be present in AVR, in lead 3, in V1. These 3 leads. Isolated Q is not diagnostic of MI. I have to look at the associated lead, either lead 2 or AVF. If there is the Q in there, I would say this is a inferior MI, otherwise not.
Yeah, thank you. I mean, that was the reason that I put this diagnosis, so that I want to see, and we always get confused with this kind of thing. Thank you. So next one.
Another thing I'd like to add regarding the QM in lead 3, if the patient take a deep, hold a breath in deep inspiration, and ECG is taken, that this Q wave disappears and R wave comes in the lead 3.
Okay, great, thank you. Give a few, maybe 20 seconds, let everybody look at it, and then please put the poll.
Yes, sir.
I think it's about 30 seconds. Let's stop the poll to see what people have said. Right. Majority said D, which is sinus rhythm left bundle branch block. There are a few answers, which I'm glad that it was there. Wadud, can you comment on choice B that I have put in the setting of a left bundle branch block?
Yeah, sir. In the presence of a bundle branch block, it's very difficult to identify inferior MI. It should not be done, ideally. But in this ECG, left bundle branch block, but the T is upright in all the lateral leads. That suggests there is ischemic origin. This is a 67-year-old female person. So we should take into that consideration. So if somebody says there is old inferior myocardial infarction, I may accept that, but my answer would be 4.
Yeah. So the choice is, in the setting of left bundle, it is very difficult to diagnose inferior MI. Also, if you look carefully in lead 3 and AVR, there is a tiny R.
Yes.
If there is a tiny R, that is not a Q wave first. But in some left bundle, you can see pure Q wave, and it is very difficult to comment on that. But what this point is well taken, in lateral chest lead, T should have been inverted, and then in the setting of left bundle. So this is not a normal finding, because this is normalized. So whatever I don't remember the clinical scenario, but so please remember that majority answered number 4, which is the correct answer. And 3% said right bundle branch back. For them, please look at lead 1, V1. Lead V1, if there is an M pattern, that will be right bundle. Small R deep S in lead 1, and wide R wave in lead V6, and a wide R wave in lead 1. This is left bundle. And right bundle should have an M pattern in lead V1 and RS pattern in lead 1 and V6. But I'm glad that you answered. I appreciate that. It is important that you try to answer these questions. We'll give about 20 seconds and then we'll start the poll.
Okay, sir. I'll start after 20 seconds.
We'll give 30 seconds for the polls, right?
Yes, sir. 30 seconds up. Here's
Okay.
the result.
All right. So majority said number 4, and let's look at number 1. Number 1 is almost correct answer, except for 2 things, that the rate is not 100 and the PR interval is not 200 milliseconds. So that's why it was wrong. Otherwise, everything else is correct. Number B, again, left bundle branch block. There's 2 persons. If you remember the last ECG, in lead 1, there is a wide R wave. In lead V1, there is a small R and deep S, and lead V6, there is a wide R wave. That was left bundle. And this is M pattern in lead V1. That's very classic for right bundle branch block. And then number 3, I put this lateral myocardial infarction, and there is a reason I put that in, and Wadud will make the comment because he is the master of this. And the reason I put it, there is a Q wave in lead 1 AVL and lead V6. But why, do you think that's the wrong answer?
Sir, the thing, is it pathological? It's not pathological. To declare a Q wave pathological, it has to be 1 millimeter or more wide, that's 40 millisecond or more, or the depth should be at least 25% of the corresponding R wave. It doesn't fulfill either of these conditions.
Thank you. So we want to start a thinking process. There is a Q wave. I wanted to find out if we can recognize that. So this is a Q wave, but it's not a pathological Q wave because it is not wider than 1 box, which is 1 millimeter, or not deeper than 25% of the QRS curve. So the correct answer is number D, sinus rhythm with PR interval 140 millisecond, rate 84, QRS 136, and right bundle branch block. Thank you.
Can I add something?
Yes.
In both the ECGs, left bundle, right bundle, you have mentioned the PR interval. For the youngsters, this is very important. For a left bundle branch block, you have to mention whether the AV conduction is quite all right or not. Because if the AV PR interval is prolonged, the patient having the chance of complete heart block in future will be a little bit higher. It's similar for right bundle branch block. So you have to put that in there. That's why SAR has put PR interval in both the right bundle and left bundle branch. And also the QR is wide. In case of right bundle, if the QR is wide is less than 120 millisecond, but more than 110 millisecond, and that's incomplete RPBB. Incomplete RPBB does not have any prognostic ill effect. But complete right bundle branch block do have some prognostic value, and patient needs more evaluation. Sir, your comment, please.
Okay. No, thank you. This one, We'll give 30 seconds to look at the ECG and then we'll put the poll. All right. I think we can stop, right? The poll. So we have everything. Atahar or Jamil.
Jamil?
This is atrial fibrillation with some specific QA changes.
Yeah. So, I mean, there was one answer of sinus rhythm with sinus arrhythmia. I mean, the reason I put it in was there is a little bit of pattern there. Almost looks like sinus arrhythmia, but it's not. It's extremely irregular RR interval. And there is no P wave. I mean, you can imagine that maybe there is a P wave somewhere, but they are not P wave. Second, the question of junctional rhythm. If it were a junctional rhythm, it would be regular and without a P wave and without a fibrillation. And it's not flutter, even though in lead V2, it looks a little coarse. But if you look at the lead before, there is no such wave. So this is not atrial flutter. So this is atrial fibrillation with non-specific Q wave changes with controlled ventricular response. So these are the commonest ECG that we see in clinical practice. That's why I thought that I'll give these ECGs. We have two more and then we'll be done. We stop the poll.
I've shared the results.
Okay. So this is, I mean, I'm happy that more people are answering these questions. Sinus rhythm, yes, it's a possibility. Rate is 136. And if you look at lead V1, there is a P wave before each QRS complex. And that makes us think sinus tachycardia. However, if we go to lead 3, 2, 3 AVF, that looks funny. And in lead 1, I don't see any P wave. So even though this is an option, then the second thing, it is very regular. And that potentially rules out atrial fibrillation. The reason I put this ventricular tachycardia diagnosis, if you suddenly look at lead 2, 3, it looks like some kind of white QRS tachycardia. But those are not the QRS complex. The QRS complexes are the narrow ones that I'm pointing to. So ventricular tachycardia is out. And most likely diagnosis from this ECG is atrial flutter with 2-to-1 conduction. Now in lead V1, you see a P wave. The way, if you look at lead 2, it looks like flutter. And the way you confirm in V1 is you put a caliper between two P wave and make it in half to see if there is another P wave. And you can see there is another P wave here. And the same patient, when the rate slows down, you can see in lead V1, you can see clearly two P waves here. In lead 2, you can see the flutter wave. So that was atrial flutter with two-tone conduction. A little bit ugly looking ECG in other one, but it was atrial flutter. Shall we stop here, or you want to continue to more ECG?
Continue this one, sir.
Okay. I think this is Wadud, Atahar, this is working. I mean, majority of people are answering correctly, and I'm sure if we continue this, probably 100%, we'll have close to 100% correct answer. So is it 30 seconds now? All right. So we have all the choices here and answer sinus rhythm with sinus arrhythmia, but there is no pattern, even though I put this choice. What we have, if you look at, we have one short RR interval and then long R1 and then continues, and then there is one beat here. So it doesn't fulfill sinus. Ventricular premature beats are wide, mostly wide, not always, but these premature beats are narrow. Atrial fibrillation is not a choice because there is P wave before each QRS complex. You can see in lead P1, clearly P wave, even though there is irregularities. So that brings us sinus rhythm with supraventricular premature beat. And if you look at it, there is few things that we do. We look at the timings also. If you look at the V2V timing, 800 millisecond, and the V2V that is enclosing the premature beat is 1260. So it is not double. So it is, we call it less than compensatory pause in supraventricular premature. That's supportive of a narrow QRS premature beat with less than full compensatory pause is 99% is supraventricular premature beat. So I think we are going to stop here unless you have any other question.
Thank you, sir. Tushar?
Sir, sir. Hello?
Yeah.
Am I audible?
Yes.
Sorry, sir, the net got disconnected for some time. And today it's disturbing much more. Prof. Sir, thank you very much. And your ever endeavor to make the ECG simpler and easier to understand has made this program successful, because we are very much popular among the young or budding cardiologists because of this fact that you try to make this ECG easy understandable, and you start from the very basics and up to that level that junior doctors can easily understand.
Thank you.
Sir, I request Atahar sir to say some words and conclude today's session.
Thank you, Tushar. Actually, it was an excellent session today. I must congratulate Dr. Shahana Zaman. Dr. Shahana Zaman recently promoted as the assistant professor. She is a teacher, still a student. She always asks questions and know about the academic problem. She is a good manager. She was a registrar and a good manager. She is an academician, organizer, and I must congratulate Shahana Zaman for your excellent, brilliant presentation and very real life ECG today. Thank you, Shahana Zaman. And I must also mention Dr. Naharuma sir. Actually, we want to hear from Dr. Naharma about the pediatric ECG. She's very much actually, I think she has got good sound knowledge about the pediatric ECG. Thank you, Naharma, for your contribution today. I want to hear from you in the next session. And I must congratulate Dr. Jamil and Chowdhury Hafiz for their contribution. Thank you, sir, for your nice presentation. And here is an announcement that the next Saturday, Dr. Shahana Zaman from Asghar Ali, Dr. Asghar Ali Hospital, sir, he will present in the next Saturday. And after that, the coming Saturday, there is the Saturday after the next Saturday, Rubik sir session. So actually, I must conclude the session today.
And sir, we have also some surprise announcement within the coming week, I hope, for February.
ঠিক আছে, তুষার তুমি বলবা?
না স্যার, এটা আমরা সামনের সপ্তাহে বলবো ইনশাআল্লাহ।
ঠিক আছে।
All right, thank you.
So Ribu, thank you very much, and thank you, sir.
Thank you, sir.
For your excellent.
Thank you.
Thank you,
Thank you, sir.
Thank you.
Assalamu alaikum, sir. Good night.
Good night.
রিভু,
জি স্যার।
তুমি ওই যে রফিক স্যারের কিন্তু আগামী শনিবারে পরের শনিবার রফিক স্যারের,
হ্যাঁ স্যার, 20 তারিখ আমি মেল দিয়ে দেব।
আর তারপরে শনিবার দিন হচ্ছে যে আমাদের ইয়ে হবে, কুইজ হবে। আচ্ছা তুমি আমাকে কিছুক্ষণ পরে ফোন করে একবার। হ্যাঁ
আচ্ছা ঠিক আছে স্যার।
আচ্ছা
ওকে, আসসালামু আলাইকুম স্যার।
আসসালাম।
Assalamu alaikum.